Most of you already know Dr. Chapman, but in case there are some on the webinar that don't, he obtained his medical degree from the University of Vermont before he came to the University of Colorado to do his general surgery residency. During that time, he did 2 years in research and got a master's of clinical science. And then he went to the University of Tennessee in Chattanooga to do colon and rectal surgery fellowship before we were lucky enough to recruit him back onto our faculty here, where he started about a year ago. So with that, Dr. Chapman will present enhanced recovery after surgery in the colorectal surgery program at University of Colorado. Dr. Chapman, thank you.
All right, thank you, Dr. McIntyre, and I'd like to thank the Department of Surgery for allowing me to present my topic today, enhanced recovery and surgery in colorectal surgery. The learning objectives for this presentation are to define what an ERAS program is and understand its utility in colorectal surgery, to identify and review the evidence supporting the individual components within an ERAS pathway, and to describe efforts to implement an ERAS pathway at the University of Colorado. Dr. Birnbaum, Dr. Kumbler, Lisa Casanova-Sadati, and Jen Bass have all been key players during this process. Why do we care about an ERAS pathway in colorectal surgery? Colorectal surgery is associated with a high morbidity and is associated with long length of stay. Surgical site infection occur in up to 20% of patients, postoperative ileus in 30% of patients, and readmission in up to 25%, which all increase hospital costs. Due to the high morbidity and costs associated with colorectal surgery, ERAS protocols were developed to reduce the physiological stress and postoperative organ dysfunction following surgery by combining evidence-based interventions in the perioperative period into a single pathway, facilitating earlier return of patient function. This meta-analysis of 13 randomized controlled trials demonstrated that an ERAS program within patients undergoing open and laparoscopic elective colorectal surgery was associated with a reduction in length of stay by 2 days and total complications by 29%. There was no difference in readmission rates or mortality between the groups. ERAS protocols typically include 15 to 20 elements combined to form a multimodal pathway. These elements span through the continuum of the preoperative, intraoperative, and postoperative pathways. In today's presentation, due to time constraints, I will focus on the elements highlighted in red. ERAS pathways start at the preoperative visit and includes patient education. It is important to set patient expectations in the preoperative visit. Patients should be encouraged to be out of bed and ambulating on the day of operation to minimize the risk of complications. I discuss an average length of stay for minimally invasive surgery is 2 to 3 days and 3 to 5 days for open surgery. Discharge from the hospital is expected when they are tolerating an oral diet, have a bowel function, and adequate pain control with oral analgesics. A clear liquid diet should be continued up to 2 to 4 hours prior to surgery. Current ASA guidelines recommend that clear liquids may be ingested for up to 2 hours before procedures requiring general anesthesia. This recommendation is based on data from randomized controlled trials comparing fasting times of 2 to 4 hours versus more than 4 hours, demonstrating equivocal gastric volume and gastric pH in adult patients. Carbohydrate loading should be encouraged before surgery in non-diabetic patients. Surgery as a form of stress is known to induce hyperglycemia, which in turn may lead to increased postoperative complications and prolonged recovery. This figure depicts the body's response to surgical stress. The body secretes a variety of hormones, which ultimately results in hyperglycemia through both increased glucose production and relative insulin resistance. In this Cochrane analysis of randomized controlled trials published in 2014, patients consuming greater than 45 grams of carbohydrates within 4 hours of surgery had increased postoperative peripheral insulin sensitivity compared to placebo or fasting. There was no difference in complication between the groups. When considering all types of surgery, including major abdominal, minor abdominal, orthopedic, and cardiac surgery, carbohydrates were associated with a small decrease in length of stay by 0.3 days. The effect of carbohydrates on reducing length of stay was most prominent among patients undergoing major abdominal surgery with a decrease of 1.66 days. A mechanical bowel preparation plus oral antibiotics before colorectal surgery is the preferred preparation. The use of a mechanical bowel prep has swung significantly on the pendulum over the years and continues to evolve. A mechanical bowel prep is thought to be an important factor in preventing infectious complications and anastomotic leak by reducing stool burden and bacterial load in the colon. Preoperative mechanical cleansing of the bowel was performed routinely in colorectal surgery until 1972, when Hughes published his personal series of patients that demonstrated no difference in infectious complications following colon surgery. Since that publication, multiple randomized controlled trials have been performed evaluating the benefit of bowel preparations prior to surgery. This Cochrane review, published in 2011, is a good summary of these randomized controlled trials. In this review, the authors evaluated 18 randomized controlled trials of 5,805 patients undergoing elective colorectal surgery and compared complications between groups. In this meta-analysis, there was no significant difference in overall anastomotic leak or wound infection between the groups. Based on these findings, guidelines including the ERAS Society guidelines published in 2012 did not recommend a routine mechanical bowel preparation. Some surgeons in the United States were slow to abandon mechanical bowel preps. This led to a NSQIP database analysis published in JACS in 2015. In this study, 5,201 patients undergoing colon cancer surgery were included, and postoperative complications and patients undergoing different bowel preparations were compared. 45% of patients received a mechanical prep only, 2% received oral antibiotics only, 28% received both mechanical and oral antibiotic preparation, and 25% received no bowel prep. The authors further categorized patients into those undergoing right-sided resection versus left-sided resection. In patients undergoing right-sided resections, oral antibiotic alone or mechanical bowel prep alone did not improve outcomes compared to no bowel prep. However, a mechanical bowel prep in addition to oral antibiotics was associated with a reduction in overall morbidity, infectious complications, and superficial surgical site infections. There was no difference in anastomotic leakage. Similarly, in patients undergoing left-sided resection, there was no benefit of oral antibiotics alone, mechanical bowel prep alone, compared to no bowel prep. However, overall morbidity, infectious complication, organ space infections, superficial infections, and anastomotic leakage was lower in patients undergoing a combined mechanical and oral antibiotic prep compared to no bowel prep. The findings of this NSQIP study led to a meta-analysis of 7 randomized controlled trials to determine whether receiving a combination of both oral and IV antibiotics with mechanical prep is superior to IV antibiotics alone with a mechanical prep in patients undergoing colorectal surgery. In this study, incisional site infections were 4.6% in the combination group compared to 12.1% in the IV antibiotics alone group, with a significant relative risk reduction of 0.38. There was no difference in organ space infections between the groups. Based on these studies, some authors have suggested that oral antibiotics are the key to reduce septic complications. This could account for the negative literature, most of which featured mechanical prep alone without oral antibiotics. However, studies to date did not have adequate sample size to evaluate the effect of oral antibiotics alone. This updated NSQIP analysis of over 40,000 patients compared outcomes between different bowel preparations. In this study, 33% of patients had no prep, 34% had mechanical prep alone, 4% had oral antibiotic prep alone, and 29% had a combined oral antibiotic and mechanical prep. As opposed to the first NSQIP study, this one also included patients undergoing proctectomy, which accounted for 28% of the patient cohort. In this study, surgical site infections were highest in the no bowel prep group at 14.4% and lowest in the combined oral and mechanical prep group at 6.5%. And there was a reduction in all types of surgical site infections, including superficial, deep, and organ space. Additionally, the anastomotic leak rate was highest in the no preparation group at 4.4% and lowest in the combined oral and mechanical bowel prep at 2.3%. On multivariate analysis, a mechanical prep alone, and oral antibiotic prep alone, and a combination of mechanical prep and oral antibiotics were all associated with a reduction in surgical site infections, anastomotic leak, ileus, major morbidity, and mortality compared to no bowel prep. Interestingly, when comparing the combined bowel prep to oral antibiotics alone, there was no significant difference in surgical site infection or an anastomotic leak between the two groups. Our colorectal surgery group currently follows the American Society of Colon and Rectal Surgeons and SAGES guidelines, which recommends both a mechanical bowel prep as well as an antibiotic bowel preparation. Lisa Casanova-Sadati has created several colorectal agile pathways, one of which includes orders for preoperative bowel preparation. Our preferred bowel preparation includes both oral neomycin and flagyl for the antibiotics and a Miralax mechanical bowel prep. Jen Bass, our nurse supervisor in the surgery clinic, has been working on a nurse-driven protocol and just received approval so that nurses can now order the mechanical bowel prep as well as the oral antibiotics in clinic. Surgical site infections are common among colorectal surgery, occurring in up to 30% of patients and are associated with increased morbidity, hospital stay, readmission, and hospital costs. Surgical site bundles are a collection of interventions aimed at reducing surgical site infections. This is a retrospective study that was published at Duke, who was found to have a significantly higher rate of surgical site infections in colorectal surgery compared to peer institutions. The authors implemented a preventative surgical site infection bundle. After matching patients using propensity scoring, a surgical site infection rates were compared between the two groups. The elements of the bundle included existing evidence-based measures. Preoperatively, patients had a chlorhexidine shower, a mechanical bowel prep with oral antibiotics, ertapenem within 1 hour of an incision, and standardization of a preparation field of the surgical field with chlorhexidine. Intraoperative measures included a fascial wound protector, gown and glove change before fascial closure, a dedicated wound closure tray, limited OR traffic, and maintenance of euglycemia and normothermia. Postoperatively, sterile dressings were removed within 48 hours and daily washings of the incisions with chlorhexidine was used. After implementation of this bundle, the percentage of surgical site infection was decreased from 19.3% to 5.7%, and the rate of postoperative sepsis was decreased from 8.5% to 2.4%. The standardized infection ratio is a risk-adjusted summary measure that compares the observed number of infections to the predicted number of infections. A score of less than 1 is better than expected, a score of 1 is similar to expected, and a score of greater than 1 is worse than expected. The predicted number of infections is based on a variety of risk factors outlined here, but I want to highlight the wound classification. This is the reason why it is so important to review the wound class with nursing staff so it is accurately recorded in the medical record and our facility can be accurately compared to other facilities across the country. So where does the University of Colorado stand? In June of 2019, we were ranked 92nd out of 93 facilities with an SIR of 1.95. This prompted motivation to implement changes to reduce the number of surgical site infections among patients undergoing colorectal surgery. This has been led by Dr. Birnbaum, Dr. Kumbler, and Lisa Casanova-Sadati, who have done a fantastic job. Our colorectal ERAS program went live on December 1st, 2019, and there have been a series of changes implemented. Our clean closure trace protocol started in June of 2020. Wound classification posters were placed in the OR in August of 2020, and we began reviewing cases for areas of improvement on a monthly basis and also a nose-to-toes chlorhexidine skin prep in September of 2020. The surgical debriefing pilot started in March of 2021 with an official rollout in May of 2021. And we began discharging patients with Hemocleanse for their wounds in July of 2021. So where are we at now? Our most recent data was pulled from the August of 2021, and our SIR score was down to 1.04 from 1.95, ranked 60 out of the 93 facilities across the country. Still not quite where we want to be, but it's a significant improvement. A minimally invasive surgical approach should be used whenever the expertise is available and appropriate. Multiple randomized controlled trials have demonstrated that minimally invasive surgery is associated with a quicker return of bowel function, has less blood loss, less postoperative pain, and a reduced length of stay. Although there was an initial concern that the oncological outcomes may be compromised by a laparoscopic approach in rectal cancer, long-term follow-up from randomized controlled trials demonstrate equivalent 2-year disease-free survival and 2-year overall survival. A multimodal opioid-sparing pain management plan should be utilized and implemented before the induction of anesthesia. Patients should be given acetaminophen, a gabapentinoid, in consideration of an NSAID preoperatively. Additionally, consideration of the postoperative pain should be discussed with the anesthesia team and may include an epidural, a lidocaine infusion, or a tap block. Thoracic epidural analgesia is commonly utilized to control patients undergoing open colorectal surgery. However, the optimal analgesic technique following open abdominal surgery within an ERAS protocol remains controversial. This meta-analysis sought to determine whether epidurals are superior to alternative analgesic techniques following open abdominal surgery within an ERAS protocol. In this meta-analysis, 7 randomized controlled trials were included, with 4 studies comparing epidural to PCA and 3 studies comparing epidural to a wound infusion catheter. There was no significant difference in the incidence of overall complications between the epidural analgesic group and alternative analgesics. However, in a subgroup analysis, an epidural was associated with an increased complication rate compared to a PCA, although the specific type of complications were not reported. There was no difference in complications between the continuous wound infusion catheters compared to the epidurals. There was also no difference in length of stay. An epidural was associated with a faster return of flatus in 3 of 4 studies, faster return of bowel movements in 4 of 6 studies, and reduced pain scores in 5 of 7 studies. What about epidurals in laparoscopic surgery? This meta-analysis evaluated the utility of epidurals versus other analgesic techniques in laparoscopic surgery within an ERAS protocol. 5 randomized controlled trials were included, and 168 patients had an epidural, and 163 patients had a variety of other analgesic techniques, as listed here. This study demonstrated an increased length of stay in the epidural group by 1 day, but there was no difference in complication rates or readmissions between the groups. Lidocaine infusions are increasingly used for perioperative pain control. This meta-analysis sought to review the evidence regarding the efficacy of systemic administration of lidocaine for postoperative analgesia and GI recovery after abdominal surgery. A total of 21 randomized controlled trials with 1,108 patients in the lidocaine group and 548 patients in the placebo group. Open surgery was performed in 15 trials and laparoscopic surgery in 6 trials. In this meta-analysis, among all patients, there was a significant reduction in pain scores at rest among patients receiving lidocaine infusion at 6 hours and 24 hours, but not at 72 hours. In a subgroup analysis of patients undergoing open surgery, there was a significant reduction in pain scores at 6 hours and 24 hours, but not at 72 hours. In patients undergoing laparoscopic surgery, there was no significant reduction in pain scores at rest at 6 hours, 24 hours, or 72 hours. It was also determined that lidocaine infusions reduce the time to first flatus and first bowel movement. When evaluating length of stay, lidocaine reduced the length of stay in the open surgery group, but not the laparoscopic group. What does the data say about tap blocks? The objective of this meta-analysis was to examine the effect of transversus abdominis plane blocks on postoperative pain after laparoscopic surgery. The authors included randomized controlled trials that compared perioperative tap blocks to a placebo or no treatment undergoing laparoscopic surgery. 10 randomized controlled trials of 633 patients were analyzed, and all patients underwent ultrasound-guided tap blocks. There was a significant reduction in pain at 4 hours in the tap block group, as well as at 24 hours. Opioid consumption after surgery was also significantly lower in the tap block group. At the University of Colorado Hospital, a lidocaine infusion was incorporated into our ERAS protocol in addition to tap blocks starting in October of 2020. We performed a retrospective review of all patients undergoing elective, minimally invasive surgery. Patients were excluded if they were taking opioids preoperatively. And we compared opioid use in 60 patients receiving lidocaine infusion postoperatively to 22 patients undergoing a laparoscopic TAP block. A mixture of ropivacaine with Decadron and Precedex was utilized for the TAP block. The primary outcome was morphine milligram equivalents postoperatively. This graph demonstrates our findings. The lidocaine infusion group is highlighted in blue and the TAP block in red. There was a statistically significant reduction in cumulative morphine milligram equivalents in the TAP block group at 12 hours, 24 hours, 36 hours, and 48 hours. There was a trend towards a clinically significant reduction at 72 hours, but this did not reach statistical significance. There were 5 documented adverse effects related to the lidocaine infusion and none reported in the TAP block group. The median length of hospital stay was 3 days in both groups, with a trend towards a lower length of stay in the TAP block group. There was no difference in complication rates between the groups, and no patients in either group had an abscess, anastomotic leak, or a bleeding requiring intervention. Intraoperatively, maintenance infusion of balanced crystalloids should be tailored to avoid excessive fluid administration and volume overload. Prior studies have demonstrated that goal-directed fluid therapy in the operating room based on objective measures reduces complications, shortens the duration of ileus, and reduces length of stay. However, more recent studies performed within the context of ERAS protocols have demonstrated no difference in outcomes. This meta-analysis sought to compare the effects of intraoperative goal-directed fluid therapy with conventional fluid therapy and to determine whether there was a difference in outcome between studies that did and did not use an ERAS protocol. 23 randomized controlled trials were included, 10 were studies within an ERAS protocol, and 13 were not. Goal-directed fluid therapy was associated with an improvement in overall morbidity in the non-ERAS studies, but not the ERAS studies. Similarly, there was an improvement in length of stay in the non-ERAS studies, but not the ERAS studies. Goal-directed fluid therapy did not improve postoperative ileus in either group. Current colorectal guidelines recommend 1.5 to 2 milliliters per kilogram per hour of balanced crystalloid infusion to maintain salt and water homeostasis. We are now going to shift gears to postoperative ERAS elements and will continue the discussion of fluid management. It is recommended that a balanced crystalloid solution, such as lactated ringers, should be utilized for postoperative fluids. Normal saline should be avoided to minimize hyperchloremic acidosis. The infusion rate should be limited to 25 milliliters per kilogram per day, which is about 75 milliliters per hour for a 70 kilogram person. IV fluid should be discontinued early in the postoperative period, with some institutions stopping after leaving the recovery room. Daily weight should be obtained to monitor volume status with a goal to limit weight gain to less than 2.5 kilograms. Additionally, it must be recognized that urine output alone is not a reliable indicator of hypovolemia in the first 48 hours after surgery, as postoperative metabolic response to stress leads to renal vasoconstriction and physiological salt and water retention. In this randomized controlled trial of patients undergoing elective colectomy, the authors sought to determine whether targeting a low minimum urine output target of 0.2 milliliters per kilogram per hour is safe when compared to the standard group of 0.5 milliliters per kilogram per hour. Fluids were administered to achieve these targets postoperatively. The primary outcome was the concentration of neutrophil gelatinase-associated lipocalin in urine on day 1 after surgery, which is a validated marker of acute tubular damage. Although still high in comparison to what is currently recommended with our ERAS protocols, the total amount of IV fluids given was significantly lower in the low volume group compared to the standard group, and this was primarily due to a reduction in fluid boluses. Urine output was significantly lower in the low group as expected. The primary outcome of urine NGAL concentration was non-inferior in the low versus standard group, suggesting that a low perioperative target for urine output is associated with significant IV fluid sparing without the increased risk of an acute kidney injury. The last few pointed discussions will discuss prevention of postoperative ileus. Patients should be offered a regular diet in the immediate postoperative period. This meta-analysis sought to compare outcomes in randomized controlled trials of patients undergoing elective colorectal surgery, comparing early oral feeding, defined as any caloric intake within 24 hours postoperatively, to the traditional oral feeding, defined as withholding oral intake until passage of flatus or stool or more than 24 hours postoperatively. 7 randomized controlled trials were included. Length of stay was significantly reduced for the early feeding group. There was no significant difference in the anastomotic leaks between the groups, and total complications were significantly reduced for the early feeding group with a risk ratio of 0.7. There was no difference in the need to insert a nasogastric tube between the groups. Chewing gum is hypothesized to reduce postoperative ileus by stimulating early recovery of gastrointestinal function through cephalovagal stimulation. In this Cochrane analysis published in 2015, the authors reviewed randomized controlled trials that used postoperative gum chewing as an intervention compared to a control group. A subgroup analysis was performed for each outcome among patients specifically undergoing colorectal surgery. Chewing gum was associated with a significant reduction in time to first flatus by 12.5 hours, a significant reduction in the time to first bowel movement by 18.1 hours, and a significant reduction in length of stay by 1 day. Alvimipan is a mu-opioid receptor antagonist that may reduce the narcotic-induced gastrointestinal motility dysfunction and decrease postoperative ileus rates. In this meta-analysis, the authors sought to determine the role of alvimipan in accelerating GI recovery and hospital discharge after open abdominal surgery performed with an ERAS pathway. 3 randomized controlled trials were included, and 785 patients received alvimipan. In this study, alvimipan was associated with a reduced time to writing hospital discharge order and a reduced time to tolerating solid food with either passage of flatus or stool. Its efficacy in laparoscopic surgery is less clear. This meta-analysis included 5 non-randomized studies undergoing right colectomy, segmental colectomy, or small and large bowel resection. Postoperative ileus occurred in 3.1% of patients receiving alvimipan compared to 12.2% in patients with no therapy. Overall, there was nearly a 75% risk reduction in the development of a postoperative ileus. The number needed to treat one postoperative ileus was 11. So in conclusion, there are multiple elements of the ERAS protocol that span throughout the perioperative period, and it is difficult to determine whether one specific intervention is superior to others because they are all generally implemented simultaneously. However, prior studies suggest that as the compliance to the number of elements increase, there is a greater improvement in patient outcomes. The overall benefits of an ERAS program include improved patient outcomes, reduced healthcare costs, and improved patient satisfaction. It is key to understand that a successful ERAS pathway requires participation and commitment from the patient, surgeon, anesthesia, nursing, physical and occupational therapy, and hospital administration. Thank you, and I'd be happy to answer any questions.
Thanks, Dr. Chapman. That was an incredible review of lots of data. So there are a few questions that have been posted into the chat. First, from Dr. Malgore, who's asking about cost effectiveness in terms of dollars saved to the healthcare system or opportunity costs to our system. Have we done an analysis like that here at University Hospital, or do you know of an analysis that's been published from another institution?
We have not done it at our facility as far as I'm aware of. There have been other prior studies that looked at cost analysis, and it's a huge variation of cost savings, anywhere from $3,000, I think it was one of the lower studies, to, several thousand, $20,000+ in other studies. It's a little bit difficult to define because time trends and changing, but there is a cost savings to the hospital.
Dr. McCarter asks about anastomotic leaks and the fact that an anastomotic leak influences so many of the other complications that you see. Do any of the ERAS bundles show a difference in anastomotic complications?
Yeah, that NISQIP study that we talked about really briefly did show a decrease in the risk of anastomotic leak. One of the benefits of the NSQIP study is there's specific PUF files, and one of those is specific to colorectal surgery where you can compare the leak rates, and it was associated with a reduction.
Dr. Vogel is asking if you could pick 3 to 5 key elements, because the list of elements of the protocols is long. Which do you think are the most effective or most important?
I think number one is pain management, trying to get some opioid sparing multimodal pain regimen, and that will lead to subsequent outcomes. I think the other, if I just select 2 other ones, it would be minimizing or stopping fluids soon after surgery and then giving them a diet. I think those will all facilitate earlier return of patient function.
Dr. Cripps is asking about elements of the ERAS protocol that could be incorporated into emergency colorectal surgery.
Yeah, that's a great question. I think that's a harder patient population in the emergent setting. And a lot of the studies, I think actually all of the studies that I discussed today, they're all in the elective setting, primarily due to the urgency. So I think that is a great topic to evaluate further and see what of these elements that we can incorporate into our tax team protocols.
Sounds like a new study to do. We still have a couple of minutes left, and Dr. Robinson asks if there are any patient-reported outcomes from ERAS protocols to get the patient perspective.
Yeah, I didn't review those specifically, but as I was reviewing the literature, there were studies that said patient satisfaction is significantly improved with an ERAS protocol. One of those was primarily related to the having clear liquids up to 2 hours to 4 hours before surgery, that their well-being and thirst was significantly improved compared to the traditional NBO after midnight.
I would imagine earlier starting of a diet after surgery would also be a big patient-reported outcome measure that would be improved with this type of protocol.
Yeah.
Great presentation. That's the last of the questions I see posted in the chat. 2 great talks this morning. Thanks everybody for attending, and have a good week.